many component parts. So we'll turn to our final presentation now. We'll hear from Associate Professor Liam Caffery from the University of Queensland. He's going to discuss his work on telehealth and how it can be used to create continuity of care. Thanks, Liam.
Thanks, Leanne. So telehealth can provide both a threat and opportunity for integrated care. So some of the threats arise from the primary care convenience providers, and I'll talk more about these shortly, or direct-to-consumer specialist services. But the opportunities arise from such models of care as eConsults, and I'm going to spend most of my presentation giving a case study on eConsults. Another opportunity is the use of telementoring. So the primary care convenience providers are primary care providers that aim at low complexity interactions such as medical certificates, prescriptions and referral letters for specialist care. We've seen the emergence of these prescription services now. They can use either an online service or an app. You search for the medication that you want. You fill out a brief pro forma and that's sent asynchronously. A doctor at the other end will review it and write a prescription and send you back an electronic prescription. So it's a very, very simple way of getting medication, particularly if you know what you're after. Like I say, the other area where there is potential threat to integrated care is the direct consumer specialist medical services, and we see these mainly arising in dermatology, and it allows people to access specialist care without a GP referral. So either the patient self-refers, or it can be used when a GP referral has expired and the patient needs long-term care needs, such as management of chronic skin conditions such as psoriasis. In these instances, the consult isn't subsidised by Medicare. So it's interesting to look at the cost structure that this teledermatology provider in Australia uses. They use, for a referred consultation, a fee of $265, rebate of $114, meaning an out-of-pocket of $150. Add to that the cost of getting a GP referral, and compare that to the right-hand screen there, that a Direct Express, which is the direct-to-consumer, where the patient will download the app, they'll take a picture of one of their skin lesions they'd like reviewed, and then they'll have a consultation with the dermatologist, a hybrid consultation that uses both asynchronous and synchronous methods to do that consultation, and there's a $200 fee. So like I say, these present a threat to integrated care, particularly in the absence of a unifying electronic health record. However, I think they are here to stay. They're based on a convenience premium, and people that actually use these services can find the convenience of them quite astounding. And I'm sure many people that use them will continue to use them. And the convenience arises that they're online or app-based. They can be asynchronous. There's little or no waiting time. There's no time away from usual activities. They're available after hours, and you can even have your prescriptions home delivered. So very, very convenient there. And other reasons why people may use those is it's less stigmatizing, it's care or family friendly, and that you don't need to take the family to the waiting room to see a clinician. And the costs aren't subsidized by Medicare, but you know, comparatively, you've got a $15 to $30 cost. I got a repeat prescription done the other day, and it was a $15 out-of-pocket expense. So very, very comparable costs, or favourable costs. So I want to look at where there are opportunities for improving integrated care using telehealth, and I want to talk about eConsults. So eConsults, the basis of these was when the Accountable Care Act was introduced in the United States, and it was a value-based payment systems. So providers looked at the most efficient way of providing access to specialist care. They originated in the integrated care providers, the usual suspects, the Kaiser Permanentes and the VAs and the Mayo Clinics. In these integrated care providers, you've got both primary care and secondary care that use the same electronic medical record. So a primary carer was able to ask for specialist advice using the electronic medical record the same way that they'd refer for a radiology or pathology. They'd refer for a specialist advice. So essentially they're asynchronous, they're typically text-based, but many systems allow you to include an image or ECG. They're provided to provider, meaning the patient's not present for these ones, and they're typically primary care to specialists. So this is a way of improving integration between primary care and specialists. And the aim of these systems was an efficient, timely way of accessing specialist care, and hopefully realise some of the benefits, such as better patient outcomes, avoided face-to-face appointments, which is important when looking at waiting lists for specialist outpatient care, some evidence for decreased cost, and the ancillary benefit of increased primary care knowledge from using these systems. So I just want to work through an example just to show how this system works, and that the GP would initiate a consult after seeing a patient. So they get onto their communication system. Like I say, it was largely electronic medical record, but there are now a number of providers that use third-party web-based products to perform e-consults. And probably the most famous of these is the Camplin-based system in Canada. The BASE is an acronym for Building Access to Specialist Care Through e-consults. So the consultation will be populated with a health summary from the patient's EMR, and the referrer would provide a question in which they wanted advice from the specialist on, and this is unexplained blood pressure that was observed in a diabetic patient. So supporting medical information such as recent laboratory tests or blood pressure measurements were packaged as part of the consult, and this was sent to the nephrologist. The nephrologist was notified that there was a case in their work queue, and then they would respond providing advice on how to manage the patient there. You can see they've recommended here some changes to dose. The nephrologist is offered the opportunity of seeing the patient in person if they don't think it can be safely handled. In this case, they didn't need to see them unless there was a reduction in renal function. So that's basically an example of how an e-consult works. So the workflow is referring clinician enters the consult question, the specialist reviews and iteratively communicates with primary care if they need additional information, and then they make a decision about whether they can handle the advice or the request electronically, or whether they would need to schedule the patient for a face-to-face consult. As I've said, these have been used in the United States and Canada predominantly for over a number of years, and there's been a number of reviews of these, and I'd just like to provide a little bit of summary information that looks at some effectiveness measures. So essentially, specialist time, you're looking at somewhere in different cases for different medical specialties and different service providers, 8 to 11 minutes. And I would suggest this compares quite efficiently with a comparable face-to-face consultations. Probably the biggest impact is for the referrer, that they need to take on additional work that may have fallen to the specialist because they need to recall the patient. They need to implement the management plan that has been provided on the advice of the specialist. As I've said, they do talk about the ancillary benefit of the educational benefit and the increased knowledge that they actually get from interacting or integrating with the specialist more so than they would if the patient saw the specialist face to face. In terms of avoided in person, you can see some of the stats here from this systematic review. Reasonably successful in reducing the number of face-to-face appointments. They use the range of about 20 to 68. And timeliness, the time to actually get advice was generally reduced when compared to a face-to-face visit. And there's a robust evidence to say that that they were cost effective, and this was normally based on a efficiency premium for the time of consult. So these eConsult systems are starting to be trialled in Australia. I've put up there the screenshot of a eConsult system, which has recently been introduced to Metro South Health, where endocrinologists at PA Hospital, Princess Alexandra Hospital in Brisbane, will provide advice to GPs based in Logan, south of Brisbane. They use bespoke web-based system called Spot On Health there, and the communication is a mix between what happens in this application and emails. So basically, general practitioner will log onto the Spot On Health system, register a case, the endocrinologist will receive notification that there's one. The specialist logs onto the system and responds, but that is sent as an email. And this is to obviate the GP having to continually log on to see if there's a response from the specialist. Queensland Health has also introduced an incentive funding pool to promote the use of eConsults. So there's a $2 million funding pool for next financial year, and you can see the definition that they've got there, which is fairly broad. And this eConsult incentive provides an additional payment of $100 for a medical officer consultation, or $50 for a nurse or allied health consultation. So just in conclusion, eConsults are a new model of care where there is an encouraging international precedent for their use. There's a number of early adopters trialling the use of these within Australia at the moment, and we're looking forward to the opportunities that this may provide in terms of evaluation research and the continued research on the use of financial incentives to promote the uptake of telehealth. And just shameless plugs. We've got a book. I've got a conference coming up, The Successes and Failures, which is going to be an in-person conference held in Brisbane on 3rd to the 5th of November. Thank you.
Thanks very much, Liam. Well, that's the end of our formal presentations for this integrated care session. We had four. I think I shouldn't lose count. We had, yeah. Anyway, a huge diversity showcase of case studies showing how providers, services and settings are working together in new and different ways to drive better integrated care. All very